Let's jump right in. We're going to look at the human vascular system today, but we aren't just looking at isolated parts. Instead, I want you to picture a massive, continuous, high-speed highway. Why does this matter? Well, because a roadblock in one tiny area is rarely just a local plumbing issue, right? It's almost always a blaring warning sign for your entire body. In this explainer, we're going to master how to manage this systemic highway, keeping the traffic flowing smoothly, and most importantly, preventing catastrophic, life-threatening pileups before they even happen. To get there, we'll be stopping at 5 main points. First, protecting the brain and carotids. Second, aortic dissection emergency protocols. Third, the kidney perfusion paradox. Fourth, treating peripheral artery disease. And finally, tying it all together with the vascular maintenance triad.
All right, part 1, protecting the brain and carotids, which really means guarding the upper highway.
Take a look at the stark contrast in these surgical thresholds. You might naturally assume that finding, say, a 50 or 60% blockage in a patient's carotid artery would mean an immediate, panicked trip to the operating room. But large-scale studies, like the ACAS and CREST trials, completely proved otherwise. Unless a patient hits these specific numbers, 70% if they're showing symptoms, or a whopping 80% if they are asymptomatic, they actually get intensive medical therapy, not surgery. Surgery carries inherent risks, right? So unless that blockage is incredibly severe, the absolute safest and most effective route is medication.
For those non-surgical patients, as well as for long-term stroke secondary prevention, this triad is our foundational defense. Let's think of it using our highway metaphor again. First up, we need aspirin to prevent the cars, our platelets, from crashing together and forming a clot. Second, a high-intensity statin comes in to literally repave the bumpy road by stabilizing the plaque itself. And third, strict blood pressure control with an ACE inhibitor or ARB acts as our speed limit, taking the stress off the vessel walls. Now, it's absolutely crucial to remember that dual antiplatelet therapy, like using aspirin and clopidogrel together, is strictly a short-term strategy, usually just 21 to 90 days for minor strokes. For the long haul, this single-agent triad is your best friend.
Moving down the body to part 2, aortic dissection emergency protocols, or how we handle a major highway blowout.
In an emergency, simply identifying whether the ascending aorta is involved completely changes a patient's fate. The Stanford classification system is beautifully simple but highly critical. If the ascending aorta is involved, that's a type A, the patient goes straight to the operating room because the risk of cardiac tamponade or stroke is just too high to wait. But if it spares the ascending aorta, a type B, they're heading straight to the ICU for aggressive medical management.
So the crucial point in the ICU for these type B patients, who, by the way, usually present with this sudden, severe tearing back pain, is getting their heart rate below 60 beats per minute. Why that specific number? Well, imagine a tearing aorta like a high-pressure fire hose with a rip in the side. Every single time the heart beats, it pumps a massive wave of pressure into that hose, and that water pressure rips the tear open just a little bit more. By slowing the heart rate down, we reduce the left ventricular contractility and fundamentally lower the shear stress on the aorta, which stops the tear from propagating any further.
This creates a completely non-negotiable order of operations for our medications. You absolutely must start with IV beta blockers like azmolol or labetalol to get that heart rate under 60. Only then can you even consider adding a vasodilator like nitroprusside to further drop the blood pressure. Starting a vasodilator before controlling the heart rate is absolutely contraindicated. If you dilate the vessels first, it's like opening the floodgates while the pump is in overdrive. The body panics, causing reflex tachycardia. The heart beats faster, it beats harder, and that radically increases shear stress. You will actually worsen the dissection. Order literally means everything here.
Okay, part 3, the kidney perfusion paradox. This is all about when heart meds actually cause harm.
We really have to ask ourselves, why would starting an ACE inhibitor, a drug widely celebrated for protecting the cardiovascular system, sometimes cause a patient's creatinine to suddenly spike, indicating acute kidney injury? It seems entirely counterintuitive, doesn't it? To understand this paradox, let's translate the medical jargon into a really simple plumbing analogy. Imagine the kidney is like a sink. In a healthy state, water flows in easily. But in patients with bilateral renal artery stenosis, meaning the main pipes feeding the kidneys are severely narrowed by plaque, the water flow coming in is dangerously low. To survive, the kidney pinches its exit pipe, the efferent arteriole, using a hormone called angiotensin II. This pinching creates back pressure, keeping the water level in the sink high enough to continue filtering. When you introduce an ACE inhibitor, you completely remove that pinch. The exit pipe dilates wide open, the pressure drops to zero, and the sink basically runs dry. The end result is a sudden, functional acute kidney injury. The immediate real-world response requires stopping the drug right away to reverse this functional insult. Because it is a functional drop in pressure rather than permanent structural damage, stopping the medication allows the kidney to recover. You also need to notify cardiology to coordinate care, especially if the drug was being used for heart failure, and utilize non-invasive imaging like a Doppler ultrasound or an MRI to confirm those underlying blockages.
Moving further down the body to part 4, treating peripheral artery disease, the end of the line.
Imagine not being able to walk down your own driveway to the mailbox without searing, gripping calf pain. That is the harsh reality of claudication, which is the hallmark of PAD. We're not talking about a random leg cramp here. It's exertional lower extremity pain that happens when a patient walks a very specific distance and then is completely and reliably relieved by simply resting. This classic symptom is a massive red flag that the distal pipes in the legs are clogging up and failing to deliver oxygen to the muscles when demand goes up.
The diagnostic threshold here is the ankle brachial index, or ABI. We simply compare the blood pressure at the ankle to the blood pressure in the arm. If that ratio drops below 0.90, the patient officially has peripheral artery disease. If it drops incredibly low, say below 0.40, we are looking at critical limb ischemia. That means the tissue is literally starving for oxygen even when the patient is completely at rest. Management here is a lot like climbing a very specific ladder of interventions, where surgery is the absolute last rung, not the first step. First, we push a supervised exercise program to build collateral circulation. Second, we initiate our foundational medical therapy. Third, we reach for specific symptom relief medications. And only fourth, if lifestyle-limiting symptoms persist or we're facing critical limb ischemia, do we finally look at surgical or endovascular revascularization. Let's zoom in on step 3 of that ladder for a second. When claudication is limiting a patient's life despite exercise and basic medical therapy, a drug called silostazol is an absolute game changer. Rather than getting bogged down in the complex biochemistry of it, just think of silostazol as a powerful chemical messenger that gives a dual command to the body. It tells the blood vessels in the legs to open up wide to improve flow, and it simultaneously commands the platelets to stop sticking together. It's incredibly effective at improving a patient's pain-free walking distance without having to immediately resort to surgery.
And finally, part 5, the vascular maintenance triad, systemic solutions for systemic problems. As we look back at our entire anatomical tour, from the neck to the chest to the kidneys all the way down to the legs, a single undeniable pattern emerges. Whether we were discussing asymptomatic carotid disease in the neck, preventing a secondary stroke in the brain, or managing claudication in the legs, this exact same triad of systemic therapy popped up every single time. A statin to lower LDL and stabilize existing plaques, antiplatelet therapy like aspirin to prevent sudden thrombosis, and strict blood pressure control, ideally with an ACE inhibitor or ARB to reduce shear stress and promote healthy vascular remodeling. So, I'll leave you with this provocative thought. Are we just fixing an isolated blocked pipe, or are we treating a systemic highway? Localized vascular interventions, whether that's carotid surgery or stents in the legs, only work when we remember to treat the whole patient. Atherosclerosis is not a local plumbing issue, folks. It is a systemic disease. If a patient has a blocked artery in their leg, you have to assume their heart and brain are at risk too. By mastering the systemic highway, we don't just relieve a symptom today, we prevent the life-threatening emergencies of tomorrow. Keep this triad in mind, and you'll be well on your way to mastering systemic vascular management.